Okay, sorry about that. I don't know what happened. All right. Then vasculature of the thoracic wall. Here, what you need to remember is that you get two points of vessels. You get the arteries coming from the descending aorta and arteries coming from the internal thoracic artery in front. So you get an anterior intercostal artery and a posterior intercostal artery in each intercostal space. Go and look that up properly. This shows it better. Then you get the venous drainage, which actually follows the arteries. In this case, I'm going a bit fast. Sorry, we have 7 minutes left. Intercostal nerves are the same. They originate from the dorsal root of the spinal nerve, there are two roots. So you get the ventral root actually coming here. The dorsal ramus goes to the back and innervates the back. So the ventral ramus or the ventral branch of the spinal nerve is the one which runs in the intercostal space. Here you can see the intercostal. Go look at these pictures separately. Right, lymphatic drainage, I've only put it for completeness sake. We're not going to really question you a lot about lymphatic drainage, right? It's a bit confusing, but you will need it for your coming years. So it's there. Right, very quickly about the pleura. Now the pleura are two bags on either side of the thoracic cage which protect the lungs. They protect the lungs as well as allow the lung to move, because these two thin films of pleurae contain in the inside the bag you get this fluid called the pleural fluid. So that is what helps the lung move when you breathe. Right? If you can appreciate how it looks like a bag here. Right. So when you take the pleura is the one in light blue, the lung is the purple structure. There are some gaps, can you see? So the pleura is actually larger than the lung. And that gives, so when you breathe in, the lung enlarges and it goes into this space and fills it up. When you exhale, push all the air out, the lung becomes smaller again. This picture shows it better. We have this thing called surface marking the pleura from your body. So you have to understand how to surface mark. You know, I told you already that the pleura extends above the clavicle. So it extends above, it comes down to the midline, towards the midline, somewhere around the second intercostal space. Both go down up to the fourth intercostal space. The right pleura keeps going down up until the sixth, whereas the left pleura, because the heart is there, it goes a bit laterally but comes back to the sixth intercostal space at the bottom edge. Thereafter, the pleura follows a course where at the mid-clavicular line, it will be at the 8th rib, at the mid-axillary line, it will be at the 10th rib, and at the paravertebral space, it will be at the 12th rib, paravertebral area. Okay. The lung is a bit different. At the top, it's the same, can you see? But after here, the sixth intercostal space, it keeps on following the sixth rib in the mid-clavicular line, eighth rib in the mid-axillary line, right? And the paravertebral, it's 10th rib. So there's a space of about 2 rib distances, which is called the costodiaphragmatic recess. That's important to know. These are the lung fissures. Have a look at that. This is how we surface mark the lung fissures. You know that the right lung has 2 fissures. It's divided into 3 lobes. The left lung has only 1 fissure. So there are only 2 lobes. The fissures continued on the back. Yes, there are 2 levels here. That's not really important or something. We might ask this. One is at T3, the other is at T4. The 2 oblique fissures. Again, this one also shows the relationship to pleura and chest wall of the lungs. Okay, lungs. This is the only way you're going to see the lungs in the living if they're not on a surgical table. You've all seen X-rays. Dr. Dari will discuss this more with you. In a cadaver, of course, we take the lungs out and we have a look at what is called the impressions. Now, because these lungs are very tightly packed in the thoracic cage, the structures in the mediastinum have left a impression, like in clay, when you press a pencil onto a block of clay, that leaves an impression. Just like that, these impressions are very important. If you take the left lung, you can see the groove for the arch of the aorta, and on the right lung you will see the groove for the esophagus vein. So you will understand this better once you learn the mediastinum. So come back to this lecture and have a look at the lung impressions, because without doing mediastinum, it's no point learning of this. This is just a preview, okay? The lung surfaces and borders I've shown here. Each lung is again a cone, right? The thorax is a cone, the lung is a cone. They're all cones. So there's an apex and a base, three borders and two surfaces. The two surfaces are, one is the costal surface, is a long, large surface all around the ribs, and the mediastinal surface, which contains all these impressions. Now, lungs, typically, I'll quickly tell you how they are divided in this picture. You start with the trachea, which is not part of the lung. The two main bronchi is the main division. It's again not part of the lung. But once the main bronchi are given out, then the lung begins, okay, proper. So each bronchus divides right into three, left into two, and each, they're called lobar bronchi, these, the lobar divisions. Each lobar bronchus divides into what we call a segmental bronchus. Segmental bronchi, you have 10 on either side. However, because of the heart, some of the bronchi on the left lung have coalesced together, or they come to like one unit. So you only technically have 9 segmental bronchi in the left and 10 on the right. You will see different things in books, right? If you have a query, just ask me after that. Then segmental bronchi branch several times and make terminal bronchioles. Terminal bronchioles go into respiratory bronchioles, which go into alveolar ducts, alveolar sacs, and alveoli. So this picture shows the segments. Can you see? Purple, the separate colors are the different lobes, but each lobe you can see is divided into segments. So the upper lobe in the right side has 3, middle lobe, only the right lung is the middle lobe, mind you, this has 2 segments, and the lower lobe has 5 segments. On the left side, you get a big upper lobe. So it has 5 segments there and 5 at the bottom. Out of this, these two are together. So you don't have a 7th segment. You don't have a medial basal segment separately. You learn these names as you go along. But for now, don't panic. You don't need to know these names. We are not going to ask you separate names. Okay? Then this, of course, this particular bronchopulmonary segment word, you have to know. It's a common question. You might be asked to draw this, name this, whatever it is. A bronchopulmonary segment is a section of the lung that can be taken out surgically. If you have a cancer in one of these segments, you can nicely take it out without damaging the rest of the lung. I'm going to finish this, the last slide, okay? So what you need to know is the bronchopulmonary segment contains a segmental bronchus. Remember the segment. So this is a bronchopulmonary segment. This 1 is 1, 2 is 1, 3 is 1. These are bronchopulmonary segments which contain a segmental bronchus, a branch pulmonary artery, a bronchial artery, which is not shown in this picture, and that is it. The veins are not part of the bronchopulmonary segment. The veins go in the wall. That is the most important thing. So it's a well-defined section. It's independent respiratory unit. It's divided from other segments by dense connective tissue, aerated by a segmental bronchus. So this slide, please remember this and make sure you can draw this picture. So now I'm going to end my lecture. This is the end of this. I will start putting things up in the SGA. If you want to contact me, I'm not going to sort of talk to you during the SGA, but if you have questions, you can WhatsApp me, or can I give you my number? I think some of you may have my number. It's not 77292 not 124. I'll put it up on the chat. Okay. Please, you can text me if you want to ask me anything in the SGA. I'll be conducting both SGAs today and tomorrow. Okay. Here's my number. Okay, I'm on WhatsApp. Please send me any messages you can. Okay, so now run, go, leave this meeting and go join Dr. Kalam's lecture. Okay, see you in the SGA.